Hello everyone, welcome to another lecture in my cardiology series. The topic is valvular heart disease. My objectives for this lecture are for you to be able to understand the physiology and classification of the various heart sounds and murmurs you're likely to encounter in normal clinical practice, and then understand the pathophysiology, classic presentation, diagnosis, classification, and treatment of the following common valvular disorders: aortic stenosis, aortic regurgitation, mitral stenosis, mitral regurgitation, and endocarditis. So no discussion of valvular disease would be complete without a discussion of heart sounds and murmurs. So to begin with, heart sounds are the short noises made by the closure of normal valves, the opening of some abnormal valves, such as the opening snap heard in mitral stenosis, and the interaction of blood with certain physiologically altered structures in the heart, which is what you might see in the tumor plop heard in atrial myxoma. In contrast, murmurs are extended sounds related to turbulent flow of blood, which would commonly be due to any of the following: a disproportionate amount of blood moving through a normal opening, which would be seen in high flow states; blood flowing through a pathologically narrow opening, which would be seen in valvular stenosis; flow opposite to the normal direction of physiological blood flow, which is seen in valvular regurgitation; and flow through an abnormal connection in the heart, such as what is seen in ventricular septal defects and other congenital heart defects. Here's a graph of the normal heart sounds, the four normal heart sounds you would hear throughout the cardiac cycle, together with a picture of the heart's electrical activity, shown in the ECG tracing, the left ventricular volume, and the pressures in the major chambers, the left atrium, shown in the dashed line on the bottom, the left ventricle, shown in the red line, and the aortic pressure, seen in the upper dashed line. S1, which represents mitral and tricuspid valve closure, as seen here, occurs right after the QRS complex on the ECG tracing and just before the C wave on the left atrial pressure tracing, corresponding to left ventricular contraction. So it's right around this point when the pressure in the left ventricle exceeds the pressure in the left atrium, where the mitral valve would close and create the S1 sound. S2, which represents aortic and pulmonic valve closure, occurs shortly after the T wave on the ECG tracing as the left ventricle relaxes. And it corresponds with this little dip in the aortic pressure tracing, which is called the dicrotic notch. S3 occurs early in diastole, and it corresponds with early ventricular filling, as seen in the Y descent on the venous tracing. Finally, S4 occurs in late diastole, just after the P wave on the ECG, and it aligns with the A wave on the venous tracing, the left atrial tracing, which represents atrial contraction. So S2 is normally divided into A2 and P2, the aortic and pulmonic components. The P2 component occurs slightly later, since the right ventricle takes a little bit longer to empty than the left ventricle. When listening for heart sounds, it's very important to listen for the split of the S2 heart sound into A2 and P2, because abnormalities of this can point to different diagnoses. First, there's normal S2 splitting, and that's just due to the increased delay in P2 compared to A2 during inspiration, as a result of the increased right-sided venous return that occurs during inspiration. So more blood flow enters the right atrium and the right ventricle during an inspiratory phase, and that leads to a delay in the emptying of the right ventricle, and that manifests as a delay in the P2 component of S2. So So in expiration, we'll have S1, and then S2, which is separated into an A2 and a P2 component. And during inspiration, the P2 occurs slightly later, so you'll again have S1, A2, and a P2. So you'll be able to hear the S2 component break up into two different sounds, particularly during inspiration. Note that this split that I'm showing here is a little bit exaggerated. Now there is a wide S2 split. This is a much more dramatic split that's, again, larger during inspiration, but still noticeable during expiration. And this would be caused by any condition that would impair right's ventricular emptying. So if there's a right bundle branch block, right-sided myocardial infarction, or pulmonic stenosis, all these conditions would cause the right ventricle to empty even slower than the left ventricle and lead to a more dramatic split. Again, in this case, you'd see in expiration, S1, so even in expiration, there's a noticeable split, but in inspiration, the split would get even wider. Paradoxical splitting is when P2 occurs before A2 and the split becomes more predominant during expiration. So the causes of this would be essentially the opposite of what would cause a wide splitting of S2, which would be anything that would unusually delay left ventricular emptying. So that would be a left bundle branch block, a left-sided MI, or aortic stenosis. In this case, during expiration, I have S1, and now you have P2 occurring before A2, since the left ventricle has a harder time emptying. And then in inspiration, the same thing happens as before. Right ventricular emptying is delayed a little bit, so P2 gets shifted a little bit closer to A2. So in this case, it's paradoxical because the split is more pronounced during expiration rather than inspiration. Finally, we have fixed S2 splitting, which occurs when the same exact degree of splitting occurs throughout the whole respiratory cycle. So it's the same degree of split during inspiration as expiration. And the most typical cause of this is an atrial septal defect, which allows the right atrium to fill from the left atrium during expiration. And this allows the right ventricle to be equally full regardless of the inspiratory phase that the patient is in, and causes the split to be the same. So in inspiration, there'll be a split with A2 occurring before P2, and in expiration, we should see the same exact pattern. A2 occurring just as much before P2. And this is what it'll sound like in practice. First, we'll listen to an S1 and a non-split S2. Now compare this to a split-sounding S2. Notice how the second beat, second sound in each set sounds like it's actually made of two different components that are almost overlapping. Typically, if it sounds like the patient has a single S2 sound during expiration and a split sound during inspiration, that's normal physiologic splitting. If you hear a split sound in expiration and an even more pronounced splitting in inspiration, that's a wide split. If you hear no splitting during inspiration, but splitting during expiration, that's suggestive of a paradoxical split. And if you hear the same exact degree of splitting in both expiration and inspiration, but can still make out the individual A2 and P2 components, that's a fixed split. Next, there's the S3 heart sound. That's the sound of atrial blood striking a pathologically compliant ventricle. In adults, this is usually seen in patients with a dilated cardiomyopathy and systolic heart failure, but it can also be a normal finding in young children and pregnant women. Let's hear how that sounds. There you'll notice that immediately after the second heart sound, you heard a distinct third heart sound, and that's S3. We can compare this to S4, which is the sound of atrial blood being pushed during atrial contraction and striking a stiffened ventricle. This occurs in late diastole, just before the start of systole. There you should have noticed a short heart sound just before the first heart sound, which sometimes is described as a gallop immediately before S1, and that's S4. You'll tend to hear S4 heart sounds in patients with thickened stiff ventricles, often as a result of chronic hypertension or aortic stenosis. In either case, the increased afterload on the left ventricle is causing the stiffness and thickening, which impairs diastolic filling. Moving on to murmurs. Whenever discussing murmurs, it's important to describe them appropriately so that you can present and document them in an effective way that will convey the most information to your attendings and peers. The components of a complete description are the timing, which would include whether the murmurs heard during systole, between S1 and S2, or during diastole, between the S2 and the next S1. The grade of the murmur from grade 1 all the way through grade 6 is a somewhat subjective classification based on the relative intensity of the murmur to S1 and S2 and the presence of a palpable vibration over the patient's chest called a thrill. Grades 1 through 3 are progressively more intense relative to the S1 and S2 sounds. Grade 4 is when a thrill is actually felt over the patient's chest. Grade 5 would be when the murmur is audible even without the stethoscope completely on the patient's chest wall. And grade 6 is when the murmur is audible even with the stethoscope slightly off the patient's chest wall. The shape of a murmur describes the pattern of how it gets louder or softer. So the most common shapes we discuss are the crescendo, decrescendo, where it gets louder then softer. Decrescendo when it just gets softer. And holosystolic, or equal intensity murmurs, have the same exact intensity throughout their cycle. The location of a murmur is where it's best heard. So there's traditionally 4 areas. On the patient's chest wall, the right upper sternal border, traditionally called the aortic area, the left upper sternal border, traditionally called the pulmonic area, the left lower sternal border, which is traditionally the tricuspid area, and the apex, which is traditionally the mitral area. The radiation of a murmur is an area other than the heart itself where a murmur can be heard. Finally, we can get a lot of information about the nature of a murmur by assessing its response to various physiologic maneuvers. These would include the murmur's intensity relative to the patient's inspiratory and expiratory cycle, the murmur's response to squatting, a Valsalva maneuver, and the hand grip. Let's look at each of these individually. So inspiration would, as we discussed before, increase the venous return to the right side of the heart, and then that would generally increase the intensity of a right-sided murmur and decrease the intensity of left-sided murmurs, whereas expiration would do the opposite. Hand grip is a maneuver that increases the left ventricular afterload, and this would decrease the intensity of murmurs that are related to forward flow of blood across the aortic valve and increase the intensity of murmurs that are related to flow of blood other than through the aortic valve. Finally, Valsalva maneuvers decrease the left ventricular preload, while squatting would actually increase the left ventricular preload and create the opposite effect. Here's an image of the heart showing the mitral valve here and the aortic valve over here. Notice how close the two valves are to each other. And to summarize, inspiration brings more venous return to the right side of the heart and increases right-sided murmurs. Hand grip increases the afterload, the pressure in the aorta, and so murmurs that depend on forward flow through the aortic valve, such as aortic stenosis and hypertrophic cardiomyopathy, would be decreased, whereas murmurs that are associated with flow into other places other than through the aortic valve, such as flow from the left ventricle to the right ventricle in a VSD, or flow from the left ventricle to the left atrium in mitral regurgitation, would be increased in intensity with a hand grip maneuver. Finally, a Valsalva maneuver would decrease the preload in the left atrium. Which would make it easier for the mitral valves to prolapse into the left atrium and worsen that murmur. It also reduces the amount of blood entering into the left ventricle during diastole, impairing diastolic filling, and that would cause the left ventricle to be more contracted during this end of diastole and worsen a hypertrophic cardiomyopathy murmur, as we'll see later. Often we'll see medical students or interns presenting on rounds that they thought they heard a murmur on a patient, and the response of the attending might be variable, ranging from disbelief to concern. But it's important for all internists and medical practitioners to understand when a murmur is actually concerning and requires further investigation. The reason is that the most common murmurs that we hear in our patients are actually benign murmurs. In adults, it's the systolic flow murmur that's caused especially in high output states such as anemia, sepsis, pregnancy, and hyperthyroidism. So if you have a patient with any of these conditions and you happen to hear a systolic murmur, it most likely is a benign flow murmur and doesn't require any further evaluation other than treating the underlying cause. But sometimes murmurs are concerning, and those are the murmurs that are diastolic, holosystolic, continuous, associated with a thrill, so grade 4 or higher, and murmurs that are associating with worrying symptoms such as angina, chest pain, heart failure, syncope, or palpitations. Patients with any of these should definitely get an echocardiogram to evaluate their valves and look for structural heart diseases. All right, starting off with the diseases involving the aortic valve. First, the aortic valve is the valve that separates the left ventricular outflow tract and ascending aorta. It typically has 3 cusps, and its purpose is to prevent backflow of blood from the aorta to the left ventricle during diastole. It opens up in early systole to let blood flow forward from the left ventricle into the aorta, and then closes at the end of systole so that blood doesn't flow backwards during diastole. Here's an image of the aortic valve. Again, note how close it is to the mitral valve. And here's a cross-sectional view of the aortic valve showing the 3 cusps. Note that 2 of the cusps have arteries coming out of them. These are the coronary arteries. Here's the right coronary artery and the left main coronary artery. That would make this the right coronary cusp. This would be the left coronary cusp. And this would be the non-coronary cusp, which does not have any artery coming out of it. It's important to keep the coronary anatomy in mind because any disease that affects the aortic valve can potentially also involve coronary blood flow as well and lead to anginal symptoms and myocardial infarction. Let's discuss aortic stenosis. This is a disorder where the aortic valve is pathologically narrow, which means that the heart has a harder time pumping blood through it during systole. Causes of valvular aortic stenosis would include calcific degeneration of the valve. This is the most common cause, usually is just age-related, and it progresses from a condition called aortic sclerosis, which is minor thickening of the valves. And once the patient starts to demonstrate hemodynamic abnormalities as seen in an echo as a result of the calcification, that's when it progresses to aortic stenosis. Another cause is a congenitally bicuspid aortic valve. This is where the aortic valve has 2 leaflets instead of the normal 3. And rheumatic heart disease. In addition to these direct valvular causes of aortic stenosis, there's a condition called hypertrophic cardiomyopathy, which can cause a subvalvular stenosis as a result of asymmetric septal hypertrophy obstructing the left ventricular outflow tract. And how would we recognize a patient in aortic stenosis? The classic symptoms are the triad of anginal chest pain, which can be due to increased demand as a result of increased aortic pressures that need to be generated, left ventricular pressures that need to be generated to overcome the aortic narrowing, as well as supply defects as a result of involvement of the coronary arteries. Syncope and dyspnea and exertion or heart failure symptoms as a result of the chronic increase in left ventricular afterload. Initially, many patients are actually asymptomatic, but these symptoms in order are the most concerning findings in a patient with aortic stenosis, and having any of these in a patient with severe stenosis will be an indication for surgery, as we'll see later. Some of the exam findings to look for are a soft or absent A2 heart sound, which is one of the most concerning prognostic findings on the physical exam. A finding termed pulsus parvus et tardus. This is the finding of a weak or delayed upstroke of the peripheral pulses compared to the heart sounds. And the murmur, which is classically described as a harsh, systolic, crescendo, decrescendo murmur, which is best heard at the aortic area, the right upper sternal border, and radiates to the carotid arteries. Here's an example of what that sounds like. Hopefully you could appreciate that the murmur was heard between S1 and S2. It has a crescendo decrescendo shape. It gets a little bit louder and then softer, and the S2 is almost absent as a result of the severe stenosis. In addition to this classic murmur, it's important to be aware of something called the Galverdine phenomenon. This is the separation of that systolic murmur into the harsh component, which is heard at the right upper sternal border, and what's described more as a musical component that's better heard at the apex. Since it's better heard at the apex and occurs during systole, it can often be confused with mitral regurgitation. But in fact, it's just a phenomenon associated with dissociation of the aortic stenosis murmur. To better understand the pathophysiology and the nature of the murmur that you hear, here's an example of the aortic pressure tracing and the left ventricular pressure tracing seen in the normal heart and the heart with aortic stenosis. So first, in the normal heart, you see that in systole, the left ventricle contracts until it reaches a point where the pressure in the ventricle is equal to the pressure in the aorta. That's when the aortic valve opens. And from this point, up until the point that the aortic valve closes over here, the aortic pressure and the left ventricular pressure are about the same. Note that the peak pressure here is about 120 millimeters of mercury, which is fairly normal. Compare that to the patient with aortic stenosis. First of all, you'll see that the pressures in the left ventricle are much, much higher, up to 200, whereas the pressures in the aorta are close to normal, around 120. So that leaves a huge gap in pressure between the left ventricle and the aorta during systole. And it's this pressure gradient that presents a really big problem for the patient. The left ventricle winds up working much, much harder than normal to maintain the same aortic pressure, and over time this really leads to symptoms of angina and heart failure. Now, the intensity of the murmur that you're going to hear is directly related to the pressure gradient that you hear, pressure gradient that you see on this graph. So early in systole, there's a very small pressure gradient between the ventricle and the aorta. During mid-systole, there's a very large pressure gradient, and then during late systole, the pressure gradient gets small again. And that's why you hear a crescendo, then decrescendo murmur. In order to further evaluate the aortic stenosis, we rely on echocardiography, and this is how it works. Here's a picture from a transesophageal echocardiogram of a patient with aortic stenosis. Here in a cross-sectional view, you can see the three cusps of the aortic valve, but they're unusually thick and bright as a result of severe calcification. And this opening in the middle is much narrower than it should be. And in this four-chamber view, you see the left atrium here, left ventricle here. This is the mitral valve. And this is the aortic valve here. As you can see, it's, again, very bright and thick with a very narrow opening. Also in this picture, you can see that the left ventricular muscle is particularly thick, and that's as a result of the increased work that the heart has to do to overcome this narrowing of the aortic valve. Here's a chart of the pressures and velocities that echocardiographers use to classify the severity of aortic stenosis. So the effective valve area is actually calculated rather than measured using the continuity equation, which states that area of flow times the velocity of flow will be constant. The peak velocity through the aortic valve is measured using pulse wave Doppler, and it operates on the principle that the narrower an opening is, the faster blood will flow through it. Finally, we can calculate pressure gradients directly from the maximum velocity using the modified Bernoulli's equation. It's not necessary to memorize all of these numbers, but If you do want to memorize something, you should be aware of the criteria for severe aortic stenosis, because that directly affects which patients should get mitral valve replacement. So how do we use these echocardiographic findings to guide our management? Well, we classify the severity of aortic stenosis into letter categories. So starting with stage A, this is a patient with risk factors for aortic stenosis, but not any hemodynamic derangements. So, similar to how stage A heart failure has risk factors, but no structural disease. These patients should just be monitored clinically. Stage B includes both the mild and moderate severities of aortic stenosis and patients who are asymptomatic. Typically, patients with symptoms attributable to the aortic stenosis automatically have severe disease. Mild aortic stenosis should get an echo repeated every 3 to 5 years, whereas patients with moderate aortic stenosis should have echo repeated every 1 to 2 years. Stage C encompasses those patients with severe but asymptomatic aortic stenosis. And that's subdivided into the C1 category, where with patients have normal ejection fractions, these patients should get echoes repeated every 6 months. And the stage 2, with the patients with reduced ejection fraction less than 50%, these patients should usually get valve replacement. Finally, there's stage D, which are the patients with both severe and symptomatic aortic stenosis. All of these patients should get valve replacement if possible. It's usually divided into 3 subtypes: D1 with preserved ejection fraction, D2 with reduced ejection fraction. This can be complicated because if the heart isn't pumping as hard as it normally does with reduced ejection fraction, the gradients and velocities may be lower than what you would need for the cutoff for severe aortic stenosis, and they may actually falsely appear as though they have lower severity aortic stenosis. In order to confirm that they actually do have severe aortic stenosis, you would perform a dobutamine stress echo. The addition of dobutamine would increase the contractility of the heart and allow it to generate the velocities and pressure gradients needed to confirm that the patient actually has severe stenosis. Finally, there's a paradoxical low flow, low gradient severe stenosis in patients with severe diastolic dysfunction. So in summary, patients with severe aortic stenosis and either low to intermediate ejection fraction, less than 50%, or symptoms should get their valve replaced. The options for replacement are surgical aortic valve replacement, or SAVR, and transcutaneous aortic valve replacement, or TAVR. And the choice of whether to perform a SAVR or TAVR would be based on the patient's comorbidities, eligibility for open heart surgery, and whether or not they would qualify for open heart surgery for an alternative diagnosis that they have, such as triple vessel disease requiring CABG. Oftentimes, we'll send patients with aortic stenosis, severe aortic stenosis, for a coronary angiogram to look for additional coronary disease that would warrant bypass before deciding on the route of surgery. It's important to note that there's no specific medical therapy that's proven to have benefit in patients with aortic stenosis. Only valve replacement is effective. If a patient isn't a candidate for valve replacement for any reason, then you should just manage their hypertension and heart failure symptoms according to the established guidelines for those conditions. But be aware that the mortality will be very high and the prognosis poor if they can't get their valve replaced. Here's a diagram of how valve replacement works using the transcutaneous approach. So here a catheter is placed through the patient's femoral artery, threaded through the aorta, goes through the aortic valve, and a balloon is then inflated across the aortic valve to open it up, and then the valve automatically attaches in place and now is able to replace the function of the patient's native valve. Coming back to hypertrophic cardiomyopathy, this is a genetic condition, an autosomal dominant mutation in a structural heart muscle protein such as troponin that leads to unusual ventricular enlargement. The most classic form is when there is asymmetric septal hypertrophy of the left ventricle, which obstructs the left ventricular outflow tract and causes a physiology and symptoms similar to aortic stenosis. In addition, the hypertrophic muscle tends to scar easily and can become a focus for fatal arrhythmias such as ventricular tachycardia, leading to sudden cardiac death. The murmur will be similar to aortic stenosis, but will worsen with Valsalva rather than get softer, and this is because the extra preload in the left ventricle when the patient isn't doing a Valsalva helps to essentially stent the left ventricular outflow tract open and diminish the sound of the murmur. Treatment for this condition will include ICD placement to prevent fatal arrhythmias and ablation of the septum, often using chemical ablation to relieve the hemodynamic obstruction. Here's a diagram of hypertrophic cardiomyopathy. Here you see the normal left ventricle with equal thickness of the myocardium across all the walls, whereas in hypertrophic cardiomyopathy, especially in the septal variant, the septal wall is unusually thick and bulges out, obstructing blood from getting out through the left ventricular outflow tract through the aortic valve. On an ECG, although neither of these findings are particularly sensitive, you might look for large QRS voltages, suggestive of left ventricular hypertrophy, deep, narrow Q waves, often referred to as dagger Q waves, particularly in the lateral leads, and secondary polarization changes, including deep T wave inversions in the precordial leads. Moving on to aortic regurgitation, this is a condition characterized by a defect in the aortic valve, which causes blood to flow retrograde from the aorta into the left ventricle during diastole. It has both acute and chronic forms. Acute forms of aortic regurgitation can be due to trauma, type A aortic dissection, or endocarditis. In acute aortic regurgitation, the left ventricle doesn't have enough time to remodel itself and adjust to the increase in volume caused by the aortic regurgitation, and the symptoms are much more dramatic and severe. Whereas chronic aortic regurgitation can be due to, again, endocarditis, rheumatic heart disease, connective tissue or rheumatologic diseases such as lupus, rheumatoid arthritis, and Marfan syndrome, as well as syphilis. Historically, syphilis carried a very strong association with aortic regurgitation. Here's a diagram of what we see in aortic regurgitation. Normally, during diastole, the mitral valve is open, allowing blood from the left atrium to flow into the left ventricle, but the aortic valve is closed, which prevents backflow of blood from the aorta. However, when the aortic valve is not working properly, it will allow this backflow blood, which will raise pressures in the left ventricle and lead to hypertrophy of the left ventricle and dilation over time if it's chronic. Patients with aortic regurgitation often present with worsening shortness of breath and exercise capacity, essentially heart failure symptoms, and in the most acute presentations, it can lead to flash pulmonary edema and hemodynamic compromise as a result of that. Chronic aortic regurgitation is most characteristically associated with an elevation of the pulse pressure So a huge difference between the systolic and diastolic blood pressures. And as a result of that, patients in the most severe forms present with classic signs, which were described by early physicians and given eponymous names. So we'll see features like the nail bed sign described by Quincke, which is where pulsations of color are seen in the patient's nail bed. There's the bounding pulse sign described by Corrigan. This is simply an exaggerated pulse felt in the femoral artery or radial artery. In the head bobbing sign, the elevation in the pulse pressure can actually be seen as the patient's head bobbing rhythmically in sync with the patient's pulse. Similarly, you can see a uvular bobbing as described by Mueller. The primary characteristic murmur of chronic aortic regurgitation is diastolic and has a decrescendo shape. It's best heard at the base of the heart. And here's what that sounds like. So hopefully you heard an S1, an S2, and immediately after the S2, a decrescendo murmur, with the fact that it's occurring immediately after S2 showing that it is a diastolic murmur. In addition to the primary murmur, there's often described what's called the Austin-Flint murmur. And this occurs because the anterior mitral valve leaflet is located very close to the aortic valve. And so when regurgitant blood flows backwards through the aortic valve, it happens to hit the anterior mitral valve leaflet, preventing it from fully opening, and that leads to essentially a functional mitral stenosis and presents with a diastolic rumble. Here's a graph of pressure tracing seen in aortic regurgitation. The effect of regurgitation from the aorta into the left ventricle is that the slope of this curve, the aortic pressures during diastole, is much steeper than it normally should be. Normally we should be looking at a curve more like this, but as a result of the regurgitation, the curve is steeper. And this curve also explains the decrescendo nature of the murmur, since the pressure difference is high in early diastole between the aorta and the left ventricle, and it gradually decreases over time. Again, we primarily use echocardiography to classify the severity of an aortic regurgitation. Here's an image from a transthoracic echocardiogram in the parasternal long axis view. The left atrium, mitral valve, left ventricle, right ventricle, aortic valve, and the aorta are all labeled here. In this case, we're using color Doppler to show where the direction of blood flow is during this phase of the cardiac cycle, which happens to be diastole. Here you see a jet of blue emerging out from the aortic valve and flowing backwards into the left ventricle, which is indicative of aortic regurgitation. There's also, again, echocardiographic criteria for gauging the severity of aortic regurgitation. These are based on calculating the regurgitant orifice area, the width of the vena contracta, which is the narrowest part of this jet. So the distance as measured here would be the vena contracta. The regurgitant volume, which is calculated from Doppler measurements, and something called the pressure half time, which relates to how quickly the pressure in the aorta drops during diastole, essentially related to the slope of the aortic pressure tracing. The steeper the slope, the worse the regurg is, and that manifests as a lower pressure half time. For the management of aortic stenosis, you should consider valve replacement in all patients with acute aortic regurgitation, as often these are surgical emergencies, patients with symptomatic severe chronic aortic regurgitation, and severe asymptomatic aortic regurgitation if their ejection fraction is less than 50 and their left ventricular end systolic diameter is greater than 50. So essentially, patients with poor EF and dilated left ventricles should be considered for surgery even if they're asymptomatic. Unlike aortic stenosis, aortic regurgitation is a condition where medical therapy is useful. The best way of managing it is to use afterload reducing agents like ACE inhibitors, ARBs, calcium channel blockers, and hydralazine, which help prevent cardiac remodeling and preserve left ventricular function for a longer period of time. Next, we'll discuss mitral valve diseases. The mitral valve is a bileaflet valve that mainly functions to prevent backflow of blood from the left ventricle into the left atrium during systole. The leaflets, the two leaflets, the anterior and posterior leaflet of the mitral valve, are anchored to papillary muscles, which emerge out of the inferior wall of the left ventricle, and they're connected to those papillary muscles by thin structures called chordae tendineae. Here's a diagram of what that looks like. You see the anterior and posterior leaflet of the mitral valve anchored to these papillary muscles coming off the inferior wall by these thin fibrous structures called the chordae tendineae. Mitral stenosis. The pathophysiology of mitral stenosis is a pathological narrowing of the mitral valve, which impairs diastolic filling of the left ventricle. This also leads to abnormally increased left atrial pressures, which progresses to pulmonary hypertension and atrial arrhythmia, such as atrial fibrillation, as a result of left atrial stretch. The most common cause of mitral stenosis worldwide is from untreated childhood rheumatic heart disease. So it's very common to see this in the U.S., apart from patients who come from other countries where they had poor access to healthcare as children. Common presentation of these patients, isolated left atrial enlargement, and this eventually progresses to right heart failure and pulmonary edema. When listening for the heart sounds, we look for an early diastolic opening snap followed by late diastolic rumbling murmur. Let's hear what that sounds like. It's a little hard to appreciate, but what you should hear is a very faint S1 and S2, followed by a loud sound, that's the opening snap, and then a rumbling murmur. The opening snap is very important because the onset of that opening snap is directly related to how severe the mitral stenosis is. The sooner the opening snap occurs relative to S2, the worse the stenosis is. To see how all this fits together, we'll look again at the pressure tracing in mitral stenosis. Here, the most notable change from the normal pressure tracing is that the left atrial pressures are much higher than normal. And you can see the left atrial pressure tracing in red with the A wave, C wave, and V wave. In diastole, the left atrial pressure is noticeably higher than the left ventricular pressure, which is not normal. And the mitral valve opens right here. which is where the left ventricular pressure drops below the left atrial pressure. And see if the left atrial pressure was higher, if the stenosis got worse, we'll draw a new curve in black to reflect the higher left atrial pressure. In this case, the opening of the mitral valve would occur here, slightly earlier in time than the patient with less severe mitral stenosis. So you can see that the opening snap is directly related to the left atrial pressure and the severity of the stenosis. On an echocardiogram, one of the most prominent features to look for, this is the parasternal long axis view again, with the left atrium, left ventricle, and the mitral valve leaflets labeled. This is the anterior mitral valve leaflet, and that's the posterior leaflet. You can see that the posterior leaflet seems to be very calcified and short, but the anterior mitral valve leaflet has this characteristic hockey stick or bent knee appearance, and that's pathognomonic for mitral stenosis. There are echocardiographic criteria for mitral stenosis, although they're less important in clinical practice. For reference, there are a low mitral valve area, less than 1 centimeter squared, a large transmitral pressure gradient, greater than 10 millimeters of mercury, elevated PA systolic pressure, and a high pressure half time. In this case, a high pressure half time is worse because it's suggesting that it's taking longer for pressures to equalize as a result of the narrowing of the valve. For management, patients with limiting symptoms should undergo either valvuloplasty or valve replacement. And another indication is severe pulmonary hypertension, which would be a mean pulmonary artery pressure greater than 50 millimeters of mercury. Medical therapy for mitral stenosis for patients who aren't valve replacement candidates include preload reduction with diuretics to reduce left atrial pressures. Here's again a diagram of how valvuloplasty works. A catheter is threaded through the IVC, enters the right atrium, then through transeptal puncture, it enters the left atrium, gets threaded through the stenotic valve, and then a balloon is inflated to open up the stenotic valve. Moving on to mitral regurgitation. This is a condition where the mitral valve remains partially open during systole, which allows retrograde flow from the left ventricle into the left atrium. Similar to aortic regurgitation, there's acute and chronic causes. Acute causes would include, again, trauma, endocarditis, and a papillary muscle rupture, which is commonly seen after an acute myocardial infarction, particularly involving the inferior wall. When the papillary muscle ruptures, the chordae are unable to hold the mitral valve leaflets closed during systole, and they flail open. Chronic causes of mitral regurgitation would include, again, endocarditis, congenital heart defects, connective tissue disorders, including lupus, left heart failure, which is a very common cause. As a result of left ventricular dilation, the mitral valve annulus is stretched open, which allows blood to leak back during systole. There's also mitral valve calcification and mitral valve prolapse, which is often seen in young women. Here's again a picture of the mitral valve. The chordae tendineae, normally anchored to the papillary muscle, hold the mitral valve leaflets closed during systole, but if there's an opening during systole, blood will get ejected out through that opening into the left atrium, causing the symptoms. The main symptoms that you're going to look for are dyspnea, worsening exercise tolerance, heart failure, and similar to mitral stenosis, atrial arrhythmia such as atrial fibrillation as a result of increased left atrial pressures and stretch. The characteristic murmur of mitral regurgitation is hollow systolic and best heard at the apex over the mitral valve area with radiation to the axilla. And here's how that sounds. Hopefully there you heard the S1 and S2 heart sounds, although they're a little bit obscured. And between them you hear a murmur that's essentially constant in intensity throughout the duration of systole. And that's why it's called a hollow systolic murmur. Mitral valve prolapse is slightly different. The valve leaflets prolapse into the left atrium slightly later during diastole, during systole, and that's associated with the sound of a mid-systolic click. And then following that prolapse, there's regurgitation and a late systolic murmur. The echocardiographic classification of mitral regurgitation is based on an assessment of Doppler flow through the mitral valve. Here we see a parasternal, we see an apical four-chamber view of the heart in a transthoracic echocardiogram. Using colored Doppler, we can get a sense of where blood is flowing. At this point during systole, we see a blue jet here indicating that blood is moving away from the probe in this direction. This is mitral valve outflow leaving the aortic valve, which is here. We see a jet of red, which indicates blood entering the left ventricle, the left atrium, rather, through the pulmonary veins. And here we see another blue jet, a very prominent blue jet, indicating that blood is flowing through the mitral valves from the left ventricle into the left atrium. And that's the jet of mitral regurgitation. Again, left ventricle, left atrium, the mitral valve, aortic valve. There are also echocardiographic criteria for gauging the severity of a mitral regurgitation, which is based on the regurgitant orifice area, the vena contracta, which is again the width of the narrowest portion of this regurgitant jet, the regurgitant volume calculated from Doppler measurements, and the regurgitant fraction, which is the easiest to appreciate visually, but also the most unreliable. That just refers to the approximate percentage of the left atrium that the regurgitant jet is filling up. In this case, it looks about close to 50%, which is suggestive that this is severe mitral regurgitation. For management of mitral regurgitation, intervention would be indicated for patients with severe symptomatic mitral regurgitation with an EF greater than 30%. It's important to treat the mitral regurgitation before the EF falls too low, below 30%, for a couple of reasons. One is that in mitral regurgitation, not all of the blood flow generated by a contraction during systole is directed through the aortic valve where it's supposed to go in order to perfuse the body. Some of it is directed backwards into the left atrium. So after the regurgitation is corrected, the increase in preload generated from the extra blood in the left atrium flowing back into the left ventricle during diastole is lost, and you actually see worsening in the cardiac output. So it's really important to treat them early when they still have good cardiac function. Patients with asymptomatic severe mitral regurgitation should get valve intervention if their ejection fraction is less than 60 and their left ventricular end systolic diameter is greater than 40 millimeters. Options for intervention include valve repair and valve replacement, and generally valve repair is chosen over replacement if possible. Medical therapy for aortic regurgitation would include afterload reduction to essentially force more blood to flow through the aortic valve rather than being regurgitated through the mitral valve, and diuresis to reduce preload and improve heart failure symptoms. In severe acute mitral regurgitation, which is a real emergency, particularly during papillary muscle rupture, you would use an inotrope such as dobutamine to help ensure forward blood flow, and nitroprusside as a potent afterload reducing agent while you're awaiting a patient getting valve replacement surgery. Moving on to endocarditis. Endocarditis is inflammation of the inner layer of the heart, the endocardium, and its associated structures, including valves. The inflammation is usually due to aggregations called vegetations, which form on the endocardium. There's infective endocarditis, which can be caused by various organisms, including fungi, Staph aureus, Veridan's group strep, Enterococcus, and the group of Hayseck organisms, which we'll discuss later. There's also non-infective endocarditis, which has a few different forms. One is the Liebman-Sachs endocarditis, which is seen in lupus and is associated with fibrin-rich vegetations located on both sides of a valve. And there's Morantic endocarditis, which is seen in malignancy and is associated with platelet-rich vegetations located on the rims of the valve. In order to diagnose endocarditis, we use the Duke criteria. You can diagnose endocarditis if two of the major criteria are met, one major and three minor criteria are met, or all five of the minor criteria are met. The two major criteria are a new echocardiographic finding of valve disease, such as new valve regurgitation, and two separate sets of blood cultures growing typical causative bacterial organisms, such as the ones we listed before. The minor criteria include vascular phenomenon, such as systemic septic emboli, which could be to the lungs and brain, and Janeway lesions, which are painless skin lesions often located on the palms and soles. Another minor criteria is the patient having any significant risk factors for developing endocarditis, which can include IV drug use or an existing valvular lesion or valve replacement, fever, immunologic phenomenon, which can include positive rheumatoid factor, Osler nodes, which are painful papules located on the fingers and toes, Roth spots, which are hemorrhages seen in the eye during a fundoscopic exam, and glomerulonephritis. Final minor criteria is a single positive blood culture or multiple blood cultures showing organisms that are non-typical causing agents for endocarditis. Here is an image of a apical four-chamber view of the heart from a transthoracic echocardiogram. You see that on the mitral valve leaflets, there's unusual structure of vegetation seen on the ventricular side of the valve, and that would be suggestive of a new valvular lesion that would satisfy the first of the major criteria. This picture, shown from a fundoscopic exam of a patient with endocarditis, shows a set of hemorrhages located in the eye, and these are the Roth spots. And then finally, we see a set of lesions on the hands and fingers. First, the painful papule located on the finger, that's the Osler node, and the painless lesion located on the palm of the patient's hand, that's the Janeway lesion, and is associated with embolization. A good history can guide us as to the most likely causative organisms of the patient's endocarditis. In a patient with a native valve, the most common organisms to look for are Veridan's group strep, which would cause a subacute, slowly progressive endocarditis. Staph aureus, which is much more aggressive and causes very acute endocarditis. And members of the HASEC group, Haemophilus, Actinobacter, Cardiobacter, Eikenella, and Kingella, which are gram-negative organisms. In IV drug users, we should watch out for Staph aureus and Candida. In a patient who recently had a prosthetic valve placed within the past 2 months, you should watch out for staph epidermidis, which is a common former of biofilms on prosthetic devices and notoriously hard to get rid of. Patients with culture-negative endocarditis, you should suspect fungal infections and negative cultures as a result of antibiotic use. And in patients with existing GI malignancies, you should suspect organisms such as Strep bovis and Enterococcus. Antibiotic therapy for endocarditis. Most bacterial infections should be treated with IV antibiotics for 4 to 6 weeks, depending on the gram stain. So if you suspect MRSA with gram-positive cocci in clusters, you should treat with vancomycin or daptomycin plus or minus rifampin. For gram-negative organisms, including HASEC organisms, choose a combination of ampicillin and gentamicin. If Pseudomonas is suspected, choose combination of piperacillin, tazobactam, or zosyn and gentamicin. And if a fungal infection is suspected, you should treat with a longer course for 6 to 8 weeks. This is also an indication for surgery, and you should choose a strong antifungal agent such as amphotericin B. The major indications for surgery in endocarditis are a patient with persistently low ejection fraction or severe mitral or aortic regurgitation causing refractory heart failure symptoms. Patients with a paravalvular abscess, as this can lead to advanced AV block. Patients with systemic septic embolization. Any patient with early prosthetic valve endocarditis, as staph epidermidis is a frequent cause of this and can cause biofilms, which can be hard to eliminate with antibiotics alone. And any fungal endocarditis, as discussed before, in addition to a longer course of antifungal therapy. Patients who would qualify for antibiotic prophylaxis prior to dental surgery to prevent endocarditis are those patients with unrepaired cyanotic congenital heart defects, patients with repaired congenital heart defects with a prosthetic device, patient with prosthetic valves, and patients who've had a cardiac transplant. Finally, I'd like to finish off this lecture with a table describing the common murmurs that we discussed and key identifying features that would help you to differentiate them. So for aortic stenosis, we're looking at a systolic crescendo-decrescendo murmur, best heard at the right upper sternal border with radiation to the carotids. The murmur would decrease with the Valsalva as a result of decreased preload in the left ventricle, leading to decreased forward flow blood through the stenotic aortic valve. And hand grip would also decrease the murmur, since an increase in the aortic afterload, a left ventricular afterload, would decrease forward flow through the stenotic valve. Once more, here's the murmur of aortic stenosis. Aortic regurgitation is a diastolic decrescendo murmur, again best heard at the right upper sternal border without radiation. Valsalva would also decrease the murmur of aortic regurgitation, as decreased left ventricular preload means that less blood is pumped out forward into the aorta to be regurgitated back. Hand grip, on the other hand, would increase the murmur of aortic regurgitation, as the increase in aortic pressures from the increased afterload would drive a higher pressure gradient for blood to flow back from the aorta into the left ventricle. Here's that aortic regurgitation murmur once more. The murmur of mitral stenosis is a diastolic, low-pitched, rumbling murmur best heard at the apex without radiation. Valsalva would decrease the intensity of this murmur by decreasing preload, essentially decreasing the amount of blood flowing into the left atrium and leading to less blood available to flow through that stenosed valve. Here's that murmur once more. The murmur of mitral regurgitation is a systolic and hollow systolic murmur in that it has the same intensity throughout the entirety of systole. It's best heard at the apex of the mitral area and radiates to the axilla. Valsalva maneuvers would increase the intensity of mitral regurgitation because it would decrease the pressure in the left atrium by decreasing the preload, and this would drive a higher pressure gradient from the left ventricle to the left atrium, which would lead to increased blood flow backwards through the mitral valve. Hand grip would increase the mitral regurgitation murmur as well, this time by increasing left ventricular afterload, which would cause blood to flow preferably through the mitral valve backwards rather than forwards through the aortic valve. Here's that murmur once again. For comparison, the murmur of hypertrophic cardiomyopathy is similar to aortic stenosis, systolic, crescendo, decrescendo, best heard at the right upper sternal border with radiation to the carotids. It would decrease with hand grip, as there would be the increase in left ventricular afterload would decrease forward flow of blood through the aortic valve, but it would increase with a Valsalva maneuver, which would help you to distinguish it from aortic stenosis, and this is because the decrease in left ventricular preload caused by Valsalva would cause the septum to bulge more in towards the left ventricular outflow tract and worsen the murmur. In contrast, squatting would increase the left ventricular preload, stretch out the ventricle, and essentially push the bulging septum away from the left ventricular outflow tract, reducing the murmur. Finally, we have the murmur of a ventricular septal defect. This is also a hollow systolic murmur, but best heard at the left lower sternal border without radiation. In contrast to the murmur of mitral regurgitation, which would increase with the Valsalva maneuver, the ventricular septal defect murmur would decrease with the Valsalva maneuver, as a decreased left ventricular preload means less blood flowing from the left ventricle to the right ventricle. And here's what a VSD murmur might sound like. And that concludes my lecture on valvular heart diseases. I hope you enjoyed. Thank you so much and have a great day.